this project is basically a collaboration between the Aga Khan University and the London School of Hygiene and Tropical Medicine. And we have a larger team. So of course we have Dr. Romina. She is our principal investigator, along with Dr. Sadia Shakur, who is on sabbatical right now, but she's one of the principal investigators. And we collaborate with Dr. Mishal Khan, who is an associate professor at London School of Hygiene and Tropical Medicine from the UK. So this project basically is sort of a collaboration. So I think the topic that I need to speak on is conflict of interest in medical practice, GPs, pharmaceutical companies, and profit-led prescribing. So I think in terms of the background, usually the interaction between pharmaceutical industry and physicians can be very useful to give physicians updated information about medicines to treat and manage various ailments. And indeed, the information can enable physicians to make a clinically informed decision so that they know the patient's unique need and act accordingly. However, this relationship can turn into a hindrance for the broader health system to perform well when particularly profit maximization takes primacy on patients' health and well-being. So there is strong evidence that pharmaceutical companies in many parts of the world, they continue to give physicians incentives such as money, cars, items for clinic and home renovation, and so much other things like sponsorships to attend academic conferences or leisure trips. So there's strong evidence for that. And this is thought to be unethical because distorting physicians' prescribing behavior can lead to certain negative outcomes for patients. For example, physicians who are in an obligatory relationship with pharmaceutical companies can prescribe unnecessary medicines to their patients, and may likely prescribe sometimes expensive medicines even when cheaper alternatives are available in the market. And they may also prescribe unnecessary medicines, for example, multivitamins or antibiotics, even when the ailments are self-resolving, such as common flu and cold. And this has very important implications in terms of antimicrobial resistance. So I think the aim of today's presentation is to discuss this conflict of interest or COI in medical practice that arises from pharmaceutical incentivization. So we are going to talk about the study background, study aims and phases, initial results from the formative phase. Then I'll discuss very briefly the intervention that we have given and some initial results from the intervention phase, and then we will conclude with some key messages. So as I gave you a background of how pharmaceutical industries interaction is important, but it can also turn into a hindrance for the broader health system. So I think the same applies in the context of Pakistan as well. So like many low and middle income countries, Pakistan has a less organized system of primary healthcare, as 80% of the urban population uses private doctors as the first point of healthcare seeking. And GPs can engage in profit-led prescribing, and this practice is enabled when pharmaceutical companies to compete in the market offer incentives to GPs to endorse or prescribe their products. And as a consequence, patient may be prescribed medicine which are not necessary, and something which has very important implications for quality of healthcare in the country. So I think we took these problems, we understood this problem, and LSHTM and AKU came together and think about how should we investigate, because we did not have a robust sort of evidence in particularly in the context of Pakistan. So first we wanted to investigate what's going on in the market, in the health market, and then we also thought about developing or co-developing an intervention that could help reduce this practice. So basically our project revolves around these 4 questions. Number 1, how is conflict of interest and professional ethics conceptualized by Pakistani policy actors, and also for GPs and pharmaceutical company representatives as well. And then we wanted to investigate which factors shape private GPs' perceptions of ethically acceptable and unacceptable incentives, and then how should these messages that sensitize private GPs to professional ethics be framed, and should sensitize to COI be combined with any other strategies to encourage behavior. And finally, what is the impact of the intervention that we are going to do. So basically, we have an exploratory part, then we have a core development of intervention part, then we have an intervention part, and then we have an evaluation part. So the study basically has three different phases: formative, intervention, and evaluation. So the formative phase, so we initiated this phase in 2020 and completed in 2021. And in this formative phase, we basically did a qualitative investigation with policy actors. So policy actors contain people from different ministries, people from regulatory bodies, for example, Sindh Healthcare Commission, Pakistan Medical Commission, DRAP, health journalist, and other people who have some sort of influence over policy, over health policy. So we conducted qualitative interviews with them, and the purpose of doing this was to see how do they understand this practice, how do they understand conflict of interest in medical practice, and particularly about the pharmaceutical incentivization and the type of incentives that pharmaceutical industry gives to physicians. Partly these interviews also help to co-develop an intervention, because we also ask questions about what could be done to reduce this practice. So based on the information that we have collected in the qualitative phase, we came up with so many suggestions that there should be harder elements that should be undertaken to reduce this practice. For example, firm laws and policies and strict regulations. But as far as we are academics, so we do not have that sort of power, and this can be very challenging as well to do some sort of things. We also had suggestions regarding soft intervention, for example, educating GPs, because when we conducted these interviews, we also learned that GPs did not formally know conflict of interest in medical practice or professional ethics in medical practice. So we ended up basically looking for an intervention that could sensitize GPs, or that could educate GPs in terms of professional ethics, so they could improve their practices. So when it comes to improvement, so we came up with three outcome measures, which is knowledge, attitude, and practices. Knowledge about professional ethics, attitudes towards pharmaceutical incentivization, and practices in terms of prescribing for patients or for in relation to pharmaceutical incentivization. So we have three outcome measures. And to measure knowledge and attitudes of GPs, we then conducted a baseline survey with a sample of more than 300 GPs based in Karachi. And once we conducted this survey, we then move ahead with the intervention phase. And this is where we conducted a randomized control trial with 419 GPs. And the intervention basically had different components. We call it multifaceted intervention. So we have a separate slide in which we'll discuss about the intervention and who collaborated and who supported us and what exactly we have done. And then we have moved ahead with the evaluation phase, which is ongoing. And it has various components. For example, we also conducted an endline survey on knowledge and attitudes of GPs. In addition to the endline survey, we also did a very novel thing, which we call the standardized pharmaceutical sales representative method, which we call SPSR method, in which we basically trained some field researchers and sent them to GP clinics who marketed certain imaginary pharmaceutical companies and assessed whether GPs were interested in pharmaceutical incentivization. So we conducted that SPSR assessment through which we measure GPs practices. So for the clarity on the unclear SPSR outcomes, we also want to conduct some qualitative interviews to understand fully the SPSR data that we have just received. Okay, so these results are from the initial qualitative formative phase. Here I'm going to talk about the incentives being offered or taken by GPs, the conditions that enable pharmaceutical incentivization in the country, particularly in the context of Karachi, and the factors that lead GPs to accept incentives. So we have, so many different kind of incentives that we have learned from the policy actors, even pharmaceutical representatives and GPs, and we classified them in terms of financial resources. For example, money, check, indirect commission through medical stores, material resources like cell phones, even car, TV, LED, air condition. So this can be used for clinics or homes. And also, I think clinical equipment, furniture, and renovation was among the material resources that pharmaceutical companies provided GPs with.
Sorry for the interruption. Just a very quick question. The GPs were very forthcoming and giving you this information?
Well, I think I don't have a perfect answer because we had a lot of challenges in discussing such sensitive things, but we crafted our questions in a way that they were not direct. They were not like, "Do you take something?" So we basically interacted them in a way that, because you are sitting in the market, you are a professional, you have more experience, so you can guide us what exactly is the reason. So basically they did not talk about themselves, but they talked about what happens generally without taking anybody's name. The pharmaceutical companies also provided GPs with sponsorships to attend conferences, and other social and recreational resources like meals, local and international holidays, tourism activities, and so on. And they also, sometimes give GPs some resources which are of family use, in a very social or cultural context. For example, they would pay children's tuition fees, daughter's dowry, Hajj pilgrimage, payment for weddings, birthdays, anniversaries, and funerals. So these are all the resources that we heard from policy actors, GPs, as well as pharmaceutical uh, company representatives, that these kind of resources are being mobilized in the private healthcare market. So now that we have learned what resources are being offered to GPs or taken by them, we also explored the conditions that enable and sustain pharmaceutical incentivization. And among those, participants were of the view that weak policies and their implementation is an issue. There's a lack of formal training in ethics that enables GPs to get pharmaceutical incentive, because they don't even recognize or distinguish between ethical and unethical practices. Incentivization has become a marketing tactic because there's a fierce competition between pharmaceutical companies, and to compete with one another, they would use incentivization as a tool to lure doctors and make some space in the market. Uh, Drugstore owners, because they are also a very important stakeholder in this whole incentivization process, because they act as a bridge between pharmaceutical companies and GPs. Because when pharmaceutical companies approach a doctor, prior to that they will approach a medical store which is adjacent to the clinic, and they will discuss certain things like GP's prescribing behavior, prescribing patterns, and things like that. So they act as a very important player in this whole incentivization process. um, and incentivization has become a norm because doctors usually think that this is their right to take incentives from different pharmaceutical companies, because at the end of the day they're going to support them, and this is not a bribe, rather this is some sort of a business arrangement. So we also explored the factors that lead GP to accept pharmaceutical incentives, and we learned about things like financial constraints that GPs experience, their expectations from the medical profession, because sometimes they enter medical profession with an ambition that they would become wealthy when they become doctors. So when they are not able to get income they expected, they would go for other options to maximize the profits from their profession. So they also uh, talk about the competition with unqualified healthcare providers, or quacks. So they say that the quacks, if we don't take incentives from pharmaceutical companies, it will make no difference, because there are a lot of quacks in the market. The pharmaceutical companies would approach them and do their job. So therefore, we have to compete, because at the end of the day they are our competitors, and we earn money less than expected due to these quacks. So they had some family obligations. So all these themes are really interwoven or interrelated, because family obligation is also linked with the expectation from medical profession, social obligations, financial constraints, and so on. So if they have to send their children in good schools, they have to earn a lot of money, and if they do not earn a lot of money, they would depend on pharmaceutical companies to give them money necessary to achieve that aim. So we also can, I'll move really quickly because we have some limited time. So we also did a baseline survey I indicated previously, in which we explored GP's knowledge on conflict of interest in medical practice. We asked these four statements. One was true, three were false. So the first statement: for a healthcare provider, a conflict of interest occurs whenever providers makes a professional decision prioritizing the potential for personal gain over the patient's best interest. This statement was true. And I think 81% answered correctly. The second statement was a conflict of interest in the clinical setting occurs only if the doctor accepts financial incentive. 33% were just correct. The third statement was a conflict of interest in medical practice is always associated with harm to patient. This statement was also false. And only 16.5% of the GPs answered correctly. The doctor is always aware if he or she is being influenced by pharmaceutical marketing practices. Only 16% answered it correctly. So GPs believe that they always know that from the pharmaceutical companies, when pharmaceutical companies attempt to influence their behavior, which is not true. So we also asked some questions which were related to their attitudes about conflict of interest in medical practice. And this is their acceptability and acceptability in some of different incentives. Medical equipments, almost 44% GPs thought that this were acceptable. Sponsorships were accepted by 43%. Few small branded items were accepted by 41%. A new air condition for a unit or a water dispenser for clinic, it was acceptable to 66.7%. A nice meal out with other doctors, it was acceptable to 6.5%. A new car was acceptable to 1% doctors. Money in the form of cash or check was accepted by 2 GPs. So as soon as we completed this phase, we then developed a multifaceted intervention in 4 different stages. And I should name a lot of people who supported us, including CBAC, in terms of giving us some advice. Dr. Faisal Ziauddin, who also participated in the intervention. Dr. Rubina Ishaq Khan was a very important player in the development of and the delivery of the intervention, and so many others. So it basically so we developed this intervention in 4 different stages. Stage 1 was to compile a brief document indicating what is acceptable, what is not acceptable. So we reviewed basically a few guidelines, available guidelines internationally or locally, and condensed them to 2 pages so that we could give these guidelines to the GPs who attend our intervention seminars. On stage 2, we developed some emotive messages. So because we also wanted to sensitize GPs through a very emotional angle as well. So this is where we collaborated with some media and communication experts and made a documentary film in which we discussed, or we basically indicated how pharmaceutical incentivization affects patients' well-being. So this was an emotive element. So once these 2 elements were completed, then we invited GPs to attend seminars. In the seminars, intervention group GPs were given seminars on conflict of interest in medical practice, in which they were sensitized on emotional grounds as well, while the control group GPs were given seminars on general clinical issues like thalassemia management, anemia management, and things like that. And this is where we also collaborated with the Sindh Healthcare Commission. We are very thankful to them because they participated in our seminars and delivered some presentations in both control and intervention groups, and they had been very important collaborators for us in terms of the successful delivery of the intervention. So once we completed the seminars, the stage 4 basically includes a slightly hard element, in which we basically sent some official letters. The letter that we have developed at stage 1, it was endorsed by PMC as well as Sindh Healthcare Commission, and we sent that letter to GP's clinic as well, so that they know that this is going to be a serious problem and they have to understand what is ethical, what is not. And we also engage them in so many other activities to just engage them and making sure that they remember all the messages that we have delivered in the seminars. And I think the important thing is that the outcome measures were knowledge, attitude, and practices, shifting their knowledge, attitude, and practice to in relation to pharmaceutical incentivization. So as I indicated earlier, that we also did an SPSR assessment in which we trained 15 field researchers. It was a very intense training for 2 weeks. We taught them about pharmaceutical marketing and how to interact with GPs and other resources that pharmaceutical representatives carry. So we constructed some three imaginary companies, and we gave them some resources like a list of medicine and things. So we send them to the GP clinics and um, to assess whether they would accept incentives from a new company. And right after their interaction with the GPs, they were supposed to complete an online questionnaire based on their interaction with the GPs. So I think these are the very, very, very initial results from this SPSR assessment. So I may not be able to comment more on that, but I think the overall picture that we have just received was that we classified, based on the SPSR data, we classified GPs into three categories. Category one is the GPs who accepted incentives from the SPSRs. Category two was were the GPs who rejected incentives from the SPSRs. And category three was no outcome. So I will explain what exactly no outcome means. Out of 267 GPs, 93 accepted pharmaceutical incentives from these SPSR in the form of different things like check, money, and so many other things. Um, and the difference between control and intervention group was 12%, which is sort of encouraging. I'm not entirely sure whether this was significant with our initial hypothesis. We still have to analyze and see whether this difference is significant, but there was difference. The GPs who received the intervention seminars, they were less likely to accept incentives. They were 41, and in the control group they were 52. So there is a 12% difference between these groups. And then 152 GPs rejected taking anything from the SPSRs. And again, there's a difference in the control intervention group. In control group, 69 GPs rejected incentives, while in intervention group, 83 GPs rejected taking anything from the SPSRs. Again, there's a 10% difference here as well in terms of control and intervention group. And in category 3 to 5, we don't know what exactly the outcome was, because these things were their GP's responses were unclear. So for example, in the first category, GPs would say that, okay, you have to come back later. So right after the interaction, GP is busy and he's saying, okay, you have to come back later, I don't have time right now. So the SPSR was supposed to meet a GP twice, not more than that, because we wanted to be as surgical as we could, based on the sensitivity of this exercise. So there was a limitation that we had to pay limited visits, and upon 2 visits, GPs continued to say, okay, you have to come back later, I don't have an answer right now. So we are not sure whether they were interested or not, but this side of GP was undetermined. The second group in this category was that GP's response was unclear. So for example, GPs continued to ignore or did not answer anything, or GP said, okay, all right. So things like that. So for example, GPs would say that the SPSRs continue to recite the script, and the GP is saying, okay, all right, okay, all right. So he did not give any answer, right? So we are not entirely sure what exactly was the outcome in terms of this group. And finally, there was a group whom the SPSRs could not meet, because there were some GPs who were on leaves, who moved permanently outside Karachi, and so many other reasons. So we had some GPs who the SPSRs could not meet with. So this was an overall snapshot from the SPSR assessment. So I think the key messages are quite clear. I think this is again a thing on which we need to have a lot of time to discuss what could be the possibilities. But I think overall, it seems like physicians have a limited understanding of conflict of interest in medical practice, as indicated in our baseline survey, and seem to think they're unaffected by pharmaceutical promotion. There are some types of incentives that physicians find acceptable and have normalized as part of the interaction with pharmaceutical companies, and they ignore the existing guidelines on medical ethics. For example, taking financial incentives with linked prescription targets, a practice which is not permitted according to the guidelines by the former PMDC, RAP, and WHO. we also have some other guidelines from different associations as well. For example, guidelines from PIMA. They have two booklets who try to distinguish between ethical, unethical sort of incentives. So we are
Also from the National Bioethics.
yeah from the National Bioethics.
And
Exactly.
also from Karachi Bioethics Group.
Yeah.
That was
Yeah.
So
We
there's
have
plenty of guidelines.
we had that booklet from Karachi Abad, and we also used this when we developed the key message document, the 2-pager document. So thank you for that, developing that document. So I think the incentives culture has evolved beyond what is covered in the existing policy documents, becoming more elaborate and woven into physicians' professional and private lives. And as such, there is need for policies and guidelines to be updated. And also, I think there is also need to be so many other actions to be undertaken. For example, in terms of monitoring, regulations, prescription controls, and so on. There could be so many other things that could be done. But I think these key messages are based on what we have just found in terms of GP's knowledge, attitude, and practices in relation to pharmaceutical incentivization. So I'm very thankful to have an opportunity to speak about this study, and any questions, comments are welcome. I and Dr. Rumina will collaboratively be able to answer all those questions. Thanks.
My question is, did you look into, did the research look into the demographics of the GPs? For example, their age group, their institutes from there they have graduated, or did they did any studies after the graduation? I feel that these things can be pertinent in developing guidelines and in targeting the right population of GPs and other doctors where we can do work.
Thank you for your question, Dr. Shahid. I think certainly we have collected some information on the demographics as well, but I think this was not sort of a major focus, I would say, but we have this information. This is because we have used so the sample universe was a list provided by the Sindh Healthcare Commission comprising 1695 GPs, and we had some limitations in terms of the eligibility criteria as well, because the GPs, so we call somebody a general practitioner who has a basic qualification like MBBS and who is operating a private clinic or doing a solo practice. So this was our limitation. But in the baseline survey, we had some questions in terms of their level of education. For example, if they have done any certification after their MBBS, and also in terms of their age, and also their clinic location, because the list that we have received from the Sindh Healthcare Commission was also contained some information about their geographic locations as well. So we had a nice distribution of JPs across all 4 districts of Karachi. So our analysis is underway, and we particularly want to investigate or examine the relationship between demographic variables and the SPSR outcomes.
So when you went to the GPs, तो were they not offended कि हमसे क्यों पूछ रहे हैं, सब तो चोर है यहाँ, मतलब ऑर्थोपोड पैसे लेता है, वो जो स्टेंट लगाता है वो लेता है, जो साइकाइट्रिस्ट से जिंदगी भर वो टेक पे रहता है. सो व्हाई आर यू आफ्टर अस? हमारे तो बहुत ही पिडली से मरीज होते हैं, उनमें से हमारा क्या मिल जाता है, हमको तो वो राइटिंग पैड देता है, हम खुश हो जाते हैं. So did you see any resentment?
Yeah, I think this is a very valid question, and we, as I earlier said, we faced a lot of trouble. I think when we conducted these interviews, because they contained very sensitive information, and GPs sort of they resisted giving some information in the first place, because they were of the view that why don't you go to consultants, and why don't you go to the private hospitals, and they named so many other entities as well, because GP is a very small portion of the overall broader health system, and why do you come and ask us these questions? So I think we basically convinced them in a way that we acknowledged this is a problem which is not just experienced by GPs. This is a problem which is more complex and which has roots in almost all the segments of the broader health system, and we will investigate in a very systematic way. So we are starting with the private GPs to get your opinion or to get your perspective, what's going on in the private market. So not only we have gotten their perspectives on the GP practice, but also we received some opinions in terms of what's going on with the unqualified healthcare providers, with consultants, with private. So we collected that information. But I think at this point in time, our focus is to do this research or examine conflict of interest in medical practice in relation to GPs. And I totally agree with expanding this study and also moving ahead with examining other segments of the broader system as well, which can be done in the future. But I think as far as this study is concerned, we are clearly focused on the general practice. And I think, let me add another thing with you as well. I think Dr. Faisal Ziauddin was there with us when we conducted the intervention. We gave some seminars on emotive and educational messages on conflict of interest in medical practice. Dr. Rubina Aga Khan was also there. And when we discussed these messages, we got a very strong reactions from GPs. And the reaction was based on two different things: the presence of unqualified practitioners in the market, and the collaboration with the role that the regulatory bodies overall play in terms of quack practice. So they were not able to sort of listen to us, what we are saying in terms of ethics, and they were not able to digest those messages. So then we came up with a strategy that in the next seminar, we convinced them in a way that we are not going to teach you. We are not here to just, give you some messages on ethics to digest, but we collected you here just to draw on your experience and get your perspective on what the problem is and how could this be resolved, right? So when we made them friends, when we sort of gave them a flexibility to share whatever they can and come to a common terms in terms of addressing the problem, then I think we came to the point where GPs could listen to us and digest those messages as well. And I think afterward, when we completed the post-intervention activities with them in terms of sending them letter, and we also engaged them in a slogan competition as well, because we asked GPs to craft some slogans and send us back so that we could hold a competition between you. And we will place the winning slogan on a group photo taken during the intervention seminars and send you back so that you could display in the clinic, right? And we received a lot of slogans, and then we constructed a panel based on 3 external members, including Dr. Faisal Ziauddin, Dr. Rubina, and one other member, who evaluated all those slogans and announced a winning one. And then we, pasted that slogan. The slogan was "My patients, my priority." So this was a slogan that was a winning slogan. So we placed that on the photograph and then, send it. So we have to basically, I think our experience was more maybe better when we made them friends and we encouraged them with so many, activities like a winning slogan and things like that.
Now, regarding the impact, how can we use your strategy to expand this type of education to reach all GPs in Pakistan? We're not talking about the particular sectors that you addressed or the Sindh Healthcare Commission's outreach, but what could be the possible way that we communicate or educate all GPs in Pakistan?
Thank you very much for the question. I think this is a very tricky question, Dr. Tashfin. There is no straightforward answer to that, because already the problem of pharmaceutical incentivization is very complex. It has so many dimensions. So I think education awareness is one dimension, right? So we have to make sure that we have proper regulation, proper implementation of them. So we have proper monitoring, for example, prescription control mechanism, something like that. So we have to do a lot of things to address this complex issue. But as far as awareness and education is concerned, I think one message that this study could potentially give is, education, keeping GPs or keeping physicians engaged with messages on ethics, professional ethics in medical practice would be useful. And I think if the CME programs could make sure that the GPs continue to receive such messages and completing short courses or certification like that could lead to the renewal of the medical licenses. This could be something useful, I think. So I think this professional ethics in medical practice topic should be a regular topic for discussion in terms of CMEs with GPs.